So hello and welcome to this new conversation at Fundación Radica. Fundación Radica is dedicated to eliminating stigma around mental health and giving information and tools that will help to improve our well-being and those of others. Today we have the amazing, great pleasure to be here with Dr. Xavier Amador, who is a clinical psychologist, an international sought-after speaker, and a professor at Columbia University Teachers College in New York City. He's the author of 8 books, including the national bestseller, I'm Not Sick, I Don't Need Help, which we'll be talking about today, as well as 120 scientific articles. He himself is a family caregiver of somebody with a mental illness. And it is also important to know he has a very long bio, so I recommend that you look him up and see the longer bio that I am not saying. But Dr. Amador has also been co-chair of the last text revision of the schizophrenia and related disorders section of the DSM-4 TR, often referred to as the Psychiatrist's Bible. Thank you so much for being with us today, Dr. Amador.
I'm happy to be here.
So, as I told you when we spoke, our at Fundación Radica this month, the book that we've been working on has been your book, I'm Not Sick, I Don't Need Help. And which has been an essential guide in giving people, therapists, and caregivers tools in order to speak to people with schizophrenia. That's your main focus, how to communicate with them in a way that it can be a fruitful relationship and treatment for them, and a fruitful relationship for the both of the people involved. I thought we could start, if it's okay with you, by defining schizophrenia, just so we all understand and have the same vocabulary.
Sure. I mean, schizophrenia and the related disorders like schizoaffective disorder and even bipolar disorder are what we call neurodevelopmental disorders. What's another example? Parkinson's disease. Someone has no tremors, no abnormal movements for most of their life, and then later in life, they develop this abnormal movement. With schizophrenia and the other disorders that I mentioned, people do not have hallucinations, hearing voices, seeing things that are not there. They do not have delusions, strange ideas that nobody shares with them. These are not political differences. These are fixed, false beliefs, like aliens have put a transmitter in my brain. I'm a very important person, and I know, the president. I'm good friends with the Pope, which, assuming these things are not true, they're delusions. So hallucinations, delusions, we see other symptoms like disorganized speech. When people think of a homeless person with schizophrenia, they often think of someone who's shouting at their voices and not making sense. They're difficult to understand, but it is an example of very disordered speech. And then we see some negative symptoms where people have difficulty expressing emotion. Their face is very flat and they speak in a very monotone voice. It's called flat affect. Those are sort of the cardinal, what we call the core symptoms of schizophrenia.
And could you explain to us a little bit how a person with schizophrenia understands relationships and understands the world?
Well, it really depends on the symptoms you have. So if you have paranoid delusions, for example, you understand relationships as threatening, as dangerous, and the world is threatening and dangerous. I guess the thing that I would say that is most common in my experience is that people with schizophrenia are some of the loneliest people I've ever met, because especially if they don't understand they're ill. And I know we're going to talk about that. But imagine, Maria, if I was saying to you, you have schizophrenia. I don't know if you do, but let's say you don't. And I keep telling you, and your family tells you, and a doctor tells you, and you do not have it. You feel very alone, very isolated. Nobody understands me. People are accusing me of being mentally ill, and I'm not, and there's nothing wrong with me. So you add to that, having delusions where maybe you think you're very special, you're a celebrity, you're married to a celebrity, and nobody believes you. The celebrity doesn't believe you. Instead, she calls the police on you when you show up at her house. Those are the kinds of experiences that so many people with schizophrenia that I've worked with over the years have. So they end up being very alone and very estranged from their loved ones, from their families especially, who are the most important people, really. They're the people who are on the front line, the people who care care the most and are most able to respond to crises.
Yeah, but it's at the same time very hard to respond. No, so that's what we'll be talking about a little bit later on. I'm not sick. I don't need help. This refers to anosognosia, right?
Yeah, yeah, very
I
well
think
said.
it's not a hard, it's not an easy word to say,
No.
but
When I have taught our program that we're going to talk about, the LEAP program in Greece, the psychiatrists all got into an argument with each other. Is it anosognosia or nosognosia? So either way, I first heard that statement, I'm not sick, I don't need help, from somebody with schizophrenia, when my brother Enrique was telling me there's nothing wrong with him. He was hearing voices. He had really strange delusions that he had killed our stepfather. He didn't do anything like that. And I was trying to explain to him, you need help, let's go see a psychiatrist. And he said, I'm not sick. There's nothing wrong with me. I don't need help. And you're the crazy one, Javi, not me. So this led to a week of trying to get him into the hospital. I ended up calling the police because my brother was suicidal, and he got better in the hospital, but he never understood. So the delusions went away, the hallucinations went away, but that unawareness of illness, which we call anosognosia, did not go away. So for 7 years, we fought and we argued. He was in and out of hospitals 3-4 times a year. He was homeless for a while, unemployed, not in school, no friends, no girlfriend, who he desperately wanted a girlfriend. And I guess I realized that what I was doing, which was common sense, trying to tell my ill brother he needed help, was just pushing him away, was just making him lonely, was just making him angry. And through my training to become a clinical psychologist during the end of that 7-year period, where my brother was doing so poorly and we fought so much, during the end of that period, I started to develop the LEAP approach. And started to understand with my patients professionally that what was working with them would work with my brother. So I called him up. I apologized for telling him that I thought he had mental illness, promised I'd never do it again. I apologized for telling him, you need to be on medication. I promise I'll never do that again. And within 6 months of that change in the way I was with him, the way I communicated with him, he accepted my suggestion for a long-acting injection of antipsychotic medication. He stayed on it for the rest of his life. He never believed he had mental illness. And why did he stay on it? I asked him in the last year of his life, I asked him, why are you taking the medication? Do you think you're ill? And he says, no, there's nothing wrong with me. And so I said, so why are you taking it? And he said, well, I do it for you. So he does it for relationships. And that's what we teach. Anosognosia, real quickly, was first described by a Hungarian psychiatrist working with Charcot, Freud's mentor in France. And he used to describe people who were paralyzed on one side of their body, neurological patients, who didn't know they were paralyzed. I've evaluated patients like this, and it's remarkable to see this. So we've known about this for over 100 years in neurological disorders. But with schizophrenia and the other disorders we're talking about today, we've known for about 25 years that we're seeing the same thing, anosognosia.
could this also be applied, as you've moved on to something else, could this also be applied to addictions?
Absolutely. I've met with some of the leaders in addiction research, and they very much believe that they're encountering anosognosia because the frontal lobes of the brain, in response to various substances, get shut down a little bit. Judgment is impaired, impulsivity is impaired, and self-awareness is impaired.
Interesting. Should we talk, because I was listening to you, and I was also thinking about reading about what I've read in the book, and and the problem with anosognosia being that then people don't follow on with their treatment. And also when you were talking about how you were saying, you need to get treated, you're sick and all of this, I felt that the person doesn't take time to look within because they're so busy fighting the other person.
Yeah. So that's one of the reasons that the main first focus of the LEAP approach is repairing the relationship and lowering the person's defensiveness. So stop trying to educate. When I educate, I get the person defensive. And when they're defensive, they have no room cognitively to look in the mirror cognitively and say, maybe I'm not doing okay, or maybe I could use some help.
They're too busy fighting,
Yes.
and they are surviving in that sense, right? That like fight and flight thing comes on to be able to introspect.
Yeah, no, that's a really good point. Too busy fighting and surviving to have insight.
Should we talk about LEAP, which we've got it's great because we've got the name right behind on your, to the side of your head, we can see LEAP Institute. So if anybody has any doubts, that's how we spell it. So we talk about LEAP,
Sure.
which is a program that you designed in
Yes.
order to give therapists and caregivers the tools to be able to communicate fruitfully with people who are sick and cannot accept it.
So I will describe it, but first let me say two things. This came out of a research study that Aaron T. Beck, the father of cognitive psychology, that Dr. Beck and I were working on together. And with his blessing, I lifted out of the therapy a communication technique, LEAP, that anyone can use. You don't have to be a therapist. And it's also evidence-based. There's research that supports the effectiveness of LEAP for helping people calm down, get into treatment. So L stands for listen, a very, very different kind of listening. It's very active. It's called active reflective listening. So when somebody says to me, Dr. Amador, I don't belong in the hospital, there's nothing wrong with me, the problem is the CIA monitoring me. Rather than reassure them, run to reassure them, now you're safe here, there's no CIA, or try to educate them, you're suffering from an illness. No, with LEAP, you reflect that back. So let me see if I understand you, Maria. Let's say you said that to me and you're a patient of mine. You're not mentally ill. You don't need to be in this hospital, right? Right. And the CIA is surveilling you. They're watching you. Is that correct? Yes. How do you feel about it? And then let's say the patient says to me, I feel very scared and angry. Then the E in LEAP is empathize. I would empathize, but in a very unique way, also make it normal, normalize what they've said. So you're angry and scared about the CIA, yes? Yeah. I would be angry and scared too. Anyone would be. And with those first two tools, and there are three others not in the LEAP acronym, but with those first two tools in particular, reflective listening and very strategic empathy, we start to lower people's defenses, like we talked about a moment ago, and people become more trusting and open because they feel understood, they feel less alone. And then we can look for the A, areas where we agree. What do we agree on? Well, we're not going to agree. If the person has anosognosia, it tends to not improve with treatment, like what happened with my brother Enrique.
Mm-hmm.
So what we do is look for other things we can agree on, like staying out of the hospital, not having the police called on you, finding a job, if you're homeless, finding a place to live. There's so many things we can agree on, and that's what we partner on. That's the P. That's what we start to problem solve and work on together.
So agreeing, sorry, just so I understand you, sorry to interrupt you, agreeing on, so understanding what is important to this person.
Yes.
And agreeing that is important and how you can work towards it. Is that it?
That's correct. But if they tell me what's important is to get back to Washington, D.C., because they're part of President Biden's cabinet and President Biden is waiting for them, we're not going to agree on that one, right? And we're not going to agree on whether or not they have mental illness, because they know they do not, and I know they do. I don't want to talk to them like that. We'll agree.
It's as real to them that they are sick as it is to you that the CIA is involved.
Exactly. Yeah. So we stay away from things we disagree on, and we shift the conversation. We pivot to, well, what can we agree on? Well, my parents are driving me crazy. They keep saying I need help. Well, maybe we can meet together with your parents and I could help them. And I actually would. I would teach the parents LEAP. I do that with many families. So what I say to them is, how many years have you tried to convince your son or your daughter that they have schizophrenia? And the families I work with will say 1 year, 5 years, 10 years. And my next question is, has it worked? You're trying to argue with them and convince them. And they laugh and say, no, that's why we're seeing you. And of course it doesn't work. And I said, well, then you're the insane one. And they always look a little bit, upset with me. I say, no. What do I mean by that? It's Einstein's definition of insanity, doing the same thing over and over and over again, expecting a different result. And you know, usually the families laugh with me and say, well, that's why we're here to see you. We want to do something different.
So we have L, we have E, we have agree, and a partner. Can we talk about partner?
Well, partner really is, once you have areas of agreement, we start to partner on ways to solve the problem. So if the problem is getting out of the hospital, I would say, look, I have a suggestion for you. With LEAP, you ask lots of questions to empower the other person. So I would say, I have an idea about how to get out of the hospital. Do you want to hear it? I ask them if they even want to hear my opinion, even though I'm the doctor, right? People are polite generally. They always say yes. Sometimes they say, I know what you're going to say. And I'll ask them, well, what do you think I'm going to say? You're going to say that I need to be on medication. And then here's important language. I say, I'm not saying you need to be on it. I'm saying if you want to get out, you may want to take it, because then the hospital can let you go. The doctors can let you go. We can let you go back home. Finding a job are things we can agree on. So in some places we have what's called supported workplaces, which are designed to help people with mental illness work, but with support. And I've had patients I've worked with who don't want to go there because those are for mentally ill people. But I can typically help them accept it. You can go, you can be helpful to those mentally ill people. You can get the work skills and get paid. And so we problem solve, we partner, because we both have agreed that the person wants a job and I want to help them get a job. Not having conflict with family, that's something we can work on together. There's many, many examples of areas where we can partner on and work together.
And of course, by asking, for example, do you want to hear it? And changing that word by need to want, you're empowering, no? And in any situation, schizophrenia being one of them, there's a huge loss of power. The whole world is a loss of power. So finding niches where we can have some power is a sort of relief and a need, no? It's a human need to know that I'm not being forced to do everything all day long.
Yes, and that my opinion matters. That
Yep.
Somebody who's using LEAP with me, how do I feel? I feel like they are not pushing anything on me. They respect my truth, my perspective, my opinions. They don't want to push anything on me. I have control of the conversation. With LEAP, that's a big part of what we do, is we create the control with the other person. We don't say that we empower people with the LEAP communication. We say we recognize that they have power.
Yeah.
And their opinion's more important than mine. Their opinion about what they need determines what they do. So, I have to work with the person where they are at in order to help them make decisions that I think would be helpful to them.
Yeah, I guess it's that word partner, right? It's more equal. There's not a hierarchy, right?
No, we're partners. But the person I'm helping, I'm glad you asked that. It's interesting. I never thought about this before, but we're partners, but I'm the junior partner. This is me down here. They're in charge, and they really are in charge. And I'm a doctor, and I'm internationally spoken all over the world. I mean, shouldn't my opinion be more important? No, my opinion doesn't matter. It really doesn't until the person is interested in my opinion. But their opinions are what drives, what determines what they do. It determines their behavior. So I have to respect and understand, embrace their opinion. And then and only then does the person become willing to listen to me and my opinion.
Yeah, and they spend 99% of their time with themselves, right? And only at most 1% of the time with you. So unless they recognize their own needs and what is important to them, it's not going to get very far, no?
Right.
And there's other words that sorry, go ahead.
You made me think about other words that are really important. Maybe you were just going to ask me this. We don't say to people, so let's say somebody says, my problem is that my mother is trying to poison me. I would reflect that back. So let me see if I understand. Your mother's trying to poison you. Did I understand that? It sounds like I'm agreeing, right? If the person says, so do you believe me that my mother is trying to poison me. Well, I don't think that, of course. Then there's another tool that's not in the acronym. It's called delay. We delay giving our opinion. So, hey, I promise I'm going to answer your question about your mother. Before I do, can you tell me more about, how you ended up here? Would that be okay? I ask permission to delay. And we want to delay so we have more opportunity for listening and empathizing with the person. We ask permission, though. Again, they have control. And then when we do give our opinion, let's say the person says, no, I want to know, do you think my mother's poisoning me? 3 A's in English. We apologize. We acknowledge that we could be wrong, our fallibility, and we agree to disagree. So how would that sound? Well, you've asked me several times, do I think your mother's poisoning you? I'm really sorry. I think this. I think it's going to upset you, and I don't want to upset you. I could be wrong. I don't see how your mother's doing that, but I don't want to argue with you. I hope we can agree to disagree. So you see how I used all three. Sometimes you can just use one. I could be wrong about this, but I think you're not the Pope. If somebody has a delusion, they're the Pope. So delaying, giving our opinion in this humble way with the 3 A's. And then also the third and last tool, there's 7 tools altogether in the LEAP approach, is apologizing for things that we've done and said that were hurtful. So with my brother, what I talked about just 10 minutes ago was I apologized for telling him he was mentally ill. I apologized for telling him he needed to be on medication. Now, why should I apologize for saying something that I believe will really help him? You should be on antipsychotic medication. I should apologize because it's insulting to him from his perspective. It's hurtful. It's pushing him away from the family because he's certain he doesn't need any such medication. So of course I'm going to apologize for the feelings that I've injured, that I've hurt.
Yeah, I was thinking also, when you have to institutionalize somebody, what a hard choice it is, and how difficult it is also for them to be institutionalized, and where that might be also a place to apologize. Absolutely,
it's very traumatic, and I've done that many times with patients. I have to testify in mental health court, and I certainly did this with my brother. I'll start with my brother. I remember the first hospitalization. He wouldn't let me visit for 2 weeks. I'd go every day. He said, I don't want to see him. He didn't want to see me. When I finally got in, I did have the sense to apologize back then. But what's important to say is maybe I was wrong. I'm sorry. I was worried. I was concerned, and that's why I did it. I hope you can forgive me. Those are the kinds of communications that I encourage people to use. Maybe I was wrong. I'm very sorry. Well, do you think you were wrong? No, I think it was the right thing to do, but I feel so sorry for how it hurt you. Thank you so much, Dr. Amador. It's been such a pleasure to speak with you, to learn from you, and so grateful for this contribution, which is essential because I think it can help people not only with schizophrenia, but with so many other illnesses. Yeah. I've used this with lots of people with eating disorders, with PTSD, with obsessive compulsive disorder, all kinds of things. Yeah, or even when, if we're going to start drifting, we can even begin to move down to when a person is just very scared or very angry and they're not completely able to communicate, how we can begin to build communication. I use LEAP with my teenager. You know what? I have 3 of those. And I'm going to use it. They want to feel heard. They want, Mom, you never listen. You never listen. Yeah. So start listening and empathizing. Yes. I think I'll do the same thing. Really nice to talk with you, Maria. It's been so nice to talk to you. Thank you so much for being with us in Radica. You're welcome.